Today, what we will be doing is we will be covering the entire biliary system from anatomy till your surgery. Basically, I'll be teaching you the anatomy and physiology of the biliary system and all the pathology, whatever you need to know about the biliary system for your competitive examinations like USMLE or NEET PG. So I am going to put a one video which collectively discusses all the high yield concepts that are related to the biliary system. Now starting with what is biliary system. Now if you see what is biliary system, it is a combined system of structures that makes, stores and transports bile. So it is not only making bile but transport bile and storing bile as well. Now the next automatic question that will come to the mind of student is what is this bile? Now bile is nothing but bile is the juice that helps in digestion and absorption of fat. Now the next question might be that what are the components of this bile? What is exactly is this juice that is helping in the digestion and absorption of fat? What are its components? One component that I'll be telling you right now is, which is an important component, is bilirubin. Now this is not just any bilirubin we are talking about. Here, what you need to know, important component of bile is conjugated bilirubin. Conjugated bilirubin, bilirubin metabolism we will discuss in a second. But let's come back to the introduction of biliary system. I have told you what is the biliary system, what is bile, what is an important component of bile. Now, what are the structures of biliary system? What are the physical structures of the biliary system? Now, there are three important physical structures of the biliary system: the liver, the gallbladder, and the bile ducts. What is the function of all these three structures? The liver is the one which makes bile. It makes bile. Gallbladder is the one which stores this bile. Bile ducts are the one which obviously transport the bile. Transport bile. Okay. Now we'll see this in the diagram. Now this is your biliary system. This diagram which I am showing you here. This is the right hepatic duct of the biliary system. This is the left hepatic duct of the biliary system. Whatever bile the liver is making, this is getting collected into these ducts. Now there is another duct which is coming from the gallbladder. Here is your gallbladder. The gallbladder. Here is your gallbladder. The duct coming from the gallbladder is the cystic duct. Left hepatic duct, right hepatic duct joined together with the cystic duct to form what this here is the common bile duct or CBD. Common bile duct gets attached or joined with a duct coming from the pancreas, which is this duct. This is the pancreatic duct, and they together open in a common opening. In what place? They open in the duodenum. Which part of the duodenum? They open specifically in the second part of your duodenum through a common sphincter, that is the sphincter of Oddi. Your sphincter of Oddi. Forgive me if my spelling of sphincter is wrong, but you get what I am telling you. Sphincter of Oddi. Now, why there is a need of the common bile duct to go and attach with the pancreatic duct and open in a single opening? It is because pancreas also helps in fat absorption and fat digestion. So it makes sense that both of the secretions are released together to combine help in fat absorption and fat digestion. Now I have told you that one of the main components, or let's say the important component of bile is bilirubin. Let's quickly revise what is the bilirubin metabolism. From where does bilirubin come from? So here you have got your RBCs, and every the life cycle of RBC is exactly 120 days, average around 120 days, after which the RBC dies, or there can also be hemolysis in the body where the RBC is dying out of some other process. So whenever RBC dies, there is release of hemoglobin, which is then broken down into heme and globulin. And from this heme, this is a multi-step process from where you get this thing called as bilirubin. Now, this bilirubin is initially unconjugated. Unconjugated. Now, this unconjugated bilirubin is made into conjugated bilirubin by the liver. By the liver. This unconjugated bilirubin, which is made into conjugated bilirubin in the liver, is made with an enzyme. And focus here because this enzyme is very important. This enzyme is UDP gluconeurosyl transferase. Remember this enzyme, as this enzyme is clinically very important. I will discuss about it later on in the lecture. Now coming back to our bilirubin metabolism. Bilirubin is made from unconjugated to conjugated. This conjugated bilirubin is excreted in the bile. Now when it is excreted in the bile, it goes into the duodenum. In the duodenum, basically in the small intestine and the large intestine. In the intestines, it is ultimately gets broken down into this product called as stercobilin. Stercobilin. Now, stercobilin is what gives it the stool its particular color. The color of the poop. The color of the poop is because of this compound stercobilin. Now, let's look at the cycle once again. If the cycle is broken, if the cycle is disrupted, let's say the cycle is disrupted here. At this particular stage, the cycle is disrupted. Over here, if the cycle is disrupted, stercobilin won't be there in the stools. So the stools will be of which color? They will be pale. They won't be having the same normal color, the same normal staining. So if a patient is there who is having pale stools, then what you need to expect is that there is disruption of bilirubin metabolism. This is what you should infer out of the patient's symptoms. Now coming to something very important, I had told you that this enzyme gluconeurosyl transferase is an important enzyme. Why it is important enzyme? Because it is important because there is something called as, now we are entering the realm of pathology. There is something called as Gilbert syndrome. There is something called as Gilbert syndrome. Now let's discuss what is this Gilbert syndrome. In Gilbert syndrome, there will be a decrease in the number, not an absolute decrease, but a decrease in the number of this enzyme UDP gluconeurosyl transferase. This enzyme UDP gluconeurosyl transferase will be in less number. the number of this enzyme is going to be less. So what will happen in Gilbert syndrome? Whenever there are periods of stress, what can be the periods of stress? The periods of stress can be dehydration, fasting, periods of intense exercise, any type of stress is there on the person. What happens is there is a slight increase in hemolysis. There is, sorry, there is a slight increase, very less increase in hemolysis. And but the normal person who is not having this enzyme deficiency, his body is able to manage this. But when this person with Gilbert syndrome, he has a deficiency of UDP gluconeurosile transferase, what is going to happen is that the body won't be able to handle the extra unconjugated hemoglobin. The body is not able to handle the extra unconjugated hemoglobin. So what will happen? If this is the liver, over here is the unconjugated hemoglobin, unconjugated bilirubin. I am sorry, I meant bilirubin. And there is a deficiency here of UDP, gluconeurosile transferase. Then this will get accumulated because this is produced in large amount. There is a deficiency over here, so this is going to get accumulated. What happened if there is accumulation of unconjugated bilirubin? There will be symptoms like mild jaundice, mild icterus, and little fatigue. So how do you diagnose this Gilbert syndrome? We diagnose clinically Gilbert syndrome if there is mild jaundice under when everything else in the blood is negative, means the reticulocyte count is normal, the total bilirubin is normal. Basically, the lab values are more or less normal. Normal lab values. Then we say that this is likely Gilbert syndrome. And what is the confirmatory thing that tells us that this is Gilbert syndrome? Is that the jaundice is self-resolving. That these, whenever the patient is having stress, whenever there are periods of stress, he develops some mild jaundice, and this mild jaundice goes away on its own without treatment. It does not cause any laboratory deformities, any laboratory abnormalities. So what is the treatment? They can ask in the exam that what is the treatment you will give for Gilbert syndrome. There is no treatment that the doctor is supposed to give for Gilbert syndrome. The only treatment for Gilbert syndrome is your assurance. Okay, this is the only treatment that you will give to the patient in Gilbert syndrome. Continuing back to our bile composition, what we have discussed so far is, what I have disclosed you is that one of the components of bile is conjugated bilirubin. We have discussed the bilirubin metabolism and one pathological state related with it, that is Gilbert syndrome. Now I will introduce to you some more components which are there in your bile. What are the some more components which are there in your bile are cholesterol. You have got your cholesterol. Then is phospholipids. Then you have got your bile acids. Now these are also there in your bile. Now what are the abnormalities that can happen because of this? See, we have discussed about bilirubin. Now let's discuss about cholesterol and the other things. Now, see, here is your gallbladder in this diagram. Here is your gallbladder. The gallbladder is storing bile. Now it is not only just storing bile, it is not just passively storing bile, but the gallbladder is also doing an important function, which is concentrating the bile. It is concentrating the bile, and it is causing saturation of the bile. Is making the bile even more better, even more concentrated. If the liver is making bile, the gallbladder is storing it and making that bile as ultra pro max. Liver is making just normal bile, the gallbladder is making the bile ultra pro max. It is concentrating it. So the more time the bile stays in the gallbladder, here is where the catch comes in. The more time the bile stays in the gallbladder, the more concentrated the bile becomes. The more concentrated the bile becomes, the more chances are there that these gallbladder will develop some stones. Some of these bile can actually form stones, and many of the times these stones are cholesterol stones. So anything, now come back to this part, anything, anything that causes stasis within gallbladder will provoke the formation of stones. Now let's discuss what are the few things which can cause stasis within the gallbladder. One thing is prolonged fasting is there. Prolonged fasting, like weight loss within a small period of time, within a small amount of time duration. Another thing is your hypercholesterolemia. Wherever more cholesterol going into the bile, more cholesterol going to the bile, more chances of forming cholesterol gallstones. Now, another thing where the body does not need to produce bile, the bile keeps getting stored and stored and stored in the gallbladder. That is when the patient is on total parental nutrition. Now, these are the states which are predisposed to form your gallstones. Now that we have discussed what are the conditions that can cause the formation of gallstones, that can predispose to the formation of gallstones. Now let's discuss something called as biliary colic. Now this is the gallbladder. This is the gallbladder, and these over here in the blue color are actually stones that have formed by whatsoever reason. The reason could be hypercholesterolemia, the reason could be total parental nutrition, the reason could be anything. Let's forget the reason. Let's imagine that the stones have now formed within the gallbladder. Now, what will happen? Whenever this person eats a fatty meal, whenever this person eats a fatty meal, in response to the fatty meal, the gallbladder is going to contract, it is going to squeeze. And whenever the gallbladder contracts, if this is the bile which is stored within the gallbladder, this is going to push outwards. When this bile gets pushed outwards, where if a stone gets stuck over here, the stone is stuck at the neck of the gallbladder. Can the bile juice come out? No, it cannot come out. And can the gallbladder contraction work in the way which it is supposed to work? No, it cannot work in the way in which it is supposed to work. So what will happen? What will happen is that now you have got a hollow organ. Gallbladder is a hollow organ which is contracting, unable to expel its contents, and because it is unable to expel its contents, it has entered into a vicious cycle of contracting more. This hollow organ contraction is going to produce, yes, it is going to produce pain. Now, the name is biliary colic. The name is biliary colic. But despite the name, it is not a Kolchiki pain. It is not a discontinuous pain. It is a continuous pain. Now, let me explain to you what will be the pattern of pain. The person eats a fatty meal. Let's say that the person has consumed a fatty meal over here at time 0. Gallbladder starts contracting. The person, this is at 45 minutes. 30 to 45 minutes. 30 to 45 minutes, the pain starts. The pain increases in intensity. After a while, it plateaus. It does not increase in intensity and it goes away. And this is very important. It goes away by 4 to 6 hours. Max to max by 4 to 6 hours. After 4 to 6 hours, you don't see any pain. The pain will go away by 4 to 6 hours. If this is 4 to 6 hours, the pain is going to go away at 4 to 6 hours. Why? Because the food has digested. The gallbladder has relaxed itself. It is no longer contracting under pressure. And the stone, within 4 to 6 hours, the stone which is stuck over here, it is going to fall back and no longer obstruct the neck of the gallbladder. This is the reason why the pain will go away on its own. And now there are something we'll discuss which needs to be discussed is that will this patient have fever? No. This is very important because it is what separates biliary colic with acute cholecystitis, that the fever will not be there. No fever is there. And how will be the pain? The pain will be dull in the upper right quadrant. It can radiate to the shoulder or back and is accompanied by nausea. Sometimes, see, whenever there is intense pain anywhere in the body, as feeling of nausea. If there is feeling of nausea, there could be vomiting. So this is what can be present, but the important thing is that there is no fever. And also the RBC, sorry, I mean the WBC. The WBC will be in normal limits. This is what you need to know. Now that I have told you what is biliary colic, let's move on to the next step, which is acute cholecystitis. Now, if you remember in the biliary colic, there is a gallstone because of stasis. It is obstructing the neck of the gallbladder or the cystic duct. Now, what happens is because of this chronic obstruction of the cystic duct, there is repeated and chronic obstruction on the cystic duct. If this is the gallbladder, this is the gallbladder, there is the chronic obstruction of the cystic duct repeated again and again and again, there is obstruction. This leads to inflammation. Now there is inflammation in the wall of the gallbladder, or if I use the exact words, inflammation in the mucosa of gallbladder. Now, this inflammation of the mucosa of the gallbladder, it is going to present almost the same way as biliary colic pain point of view, but there will be some difference. What are the differences? I have told you here while explaining biliary colic that here there will be no fever. In biliary colic there is no fever, but whereas in acute cholecystitis there is fever. And here I have told you that the WBC will be normal. Here the WBC will be elevated. There will be leukocytosis. Another thing about the pain. The pain of the biliary colic, I have told you, it will go down. It will go down by maximum 6 hours. Here the pain will not go down, not go down even after, let's say, 6 hours. This is what is cholecystitis. Now, what is the treatment for cholecystitis? Immediate treatment is supportive care. The immediate treatment is supportive care. You can give the IV fluids, hydration, etc. But once the patient is stabilized, once the patient is out of the pain, you have to do elective cholecystectomy. Cystectomy, where you remove the gallbladder, where you will remove the gallbladder. Now let's come to a condition which is even more severe, which is even the next step of acute cholecystitis. So first what we have done is we have done discussed biliary colic. After biliary colic, we have discussed acute cholecystitis. Now, if you have noticed, I am moving in a step ladder fashion. It means that I am moving in a step ladder fashion like this. Slowly, I am increasing the severity. Now, coming back to acute cholangitis. In acute cholangitis, what will happen is if this is your liver, here is your gallbladder, here is the cystic duct. This part, if this is the cystic duct. I have told you that in acute cholecystitis, the obstruction is here in the cystic duct. Now, here what will happen is the both the hepatic ducts meeting and forming the common bile duct. Both the cystic duct and the hepatic ducts, they are meeting and forming the common bile duct. Now at this point where there is formation of common bile duct, let's imagine if there is obstruction over here. At this point, what is going to happen is whenever there is obstruction in of the common bile duct, there is a pathway, there is a chance, there is an opportunity for bacteria to basically invade up and cause infection of the biliary tree, infection of the biliary tree. Coming back again, let's revise. Biliary colic, where the gallbladder is contracting against the biliary stone. The stone is obstructing the gallbladder is contracting against it. It produces cone, that is the simple biliary colic. No fever, no leukocytosis, the pain will go away, increase the severity. Acute cholecystitis. Now there is obstruction of cystic duct. Because of this obstruction, there is inflammation of the mucosa of the gallbladder. Still, it is not sure shot infection of the biliary tree. Now we are increasing the severity. Here, it acute cholangitis. There is infection of the biliary tree. This infection of the biliary tree is very dangerous. It can lead to sepsis and it could be fatal also. Now, what are the presentation of acute cholangitis? What is the presenting feature? Here you can never forget Charcot striatum. Charcot's triad. Now, what is this Charcot's triad? Charcot triad is right upper quadrant pain with jaundice with fever, with jaundice and with fever. That is the Charcot's triad. Now, let's say why there is jaundice, you will ask me. Right upper quadrant pain because the gallbladder is located in the right upper quadrant. I am sorry, the right upper quadrant. Why jaundice? Jaundice is because there is obstruction of the biliary tree, so it is going to cause jaundice. And why fever? Because it is a bacterial infection. This is the Charcot's triad. If this is how the patient of acute cholangitis is going to present to you, if at the time the condition goes unrecognized, it can lead to Reynolds pentad. Reynolds pentad. What is Reynolds pentad? Just add the Charcot triad plus hypotension and altered mental status. Add these to the Charcot's triad, you will get the Reynolds pentad. Now, coming to one thing which I have forgot while teaching acute cholecystitis is that in acute cholecystitis there will be something called as positive Murphy's sign. Positive Murphy's sign. What is positive Murphy's sign? Whenever you press along the right side mid clavicular line below the costal margin, the patient displays a pain while pressing over here. This is called as positive Murphy's sign. It is a sign of acute cholecystitis. It is a sign of inflammation of the gallbladder. Whereas here in acute cholangitis, if a patient is presenting with acute cholangitis, you suspect it is acute cholangitis, you should immediately do the ultrasound. On the ultrasound, what will the patient have? It will show dilation of biliary tree. That dilation of biliary tree is because of obstruction somewhere. So the back part becomes dilated. Then what do? You remove this obstruction, you clear away this obstruction with the help of ERCP. You ERCP with the help of ERCP, you clear away this obstruction, and ERCP should be done in 12 to 24 hours or 1 to 2 days. That depends from book to book, but you start with antibiotics, start immediately with antibiotics, and then you go for ERCP. Later on you can do cholecystectomy also. Now we'll be coming to what are the lab findings in acute cholangitis. In the lab findings, very obvious point is that the WBC the WBC will be elevated. This is very obvious. Another thing, but over here is there will be a mild elevation of liver enzyme, mild increase of transaminases. How mild increase? The general value is that AST, ALT should be below 40. It may go up to 60 or 80 over here. And other than that, alkaline phosphatase increases. So ALP, alkaline phosphatase also increases. And what kind of hyperbilirubinemia will be there? There will be direct or conjugated increase in bilirubin also. So this is the laboratory values you will see in case of acute cholangitis. Now, what we have discussed. We have discussed biliary colic. We have discussed acute cholecystitis. We have discussed acute cholangitis. Now let's come to a condition which is called as emphysematous cholecystitis. Emphysema means air. Emphysematous means air-filled. Cholecystitis is inflammation of the gallbladder and cystic duct. Now, what are the risk factors for emphysematous cholecystitis? Who can get these air filled where there is air forming within the gallbladder and the cystic duct? But first of all, let me tell you how there is air in the gallbladder and the cystic duct. There is cholangitis, there is bacterial invasion of the gallbladder. Once there is bacterial inflammation of the gallbladder, there are some bacteria of Clostridium, Clostridium and Escherichia E. coli. Your E. coli and Clostridium, some gas forming bacteria are there which lead to this, but it does not affect all individuals. It affects only certain individuals who are having either critical illness, who are immunocompromised, or their ability to fight with infection has been very less, but not specifically immunocompromised. What is that type of individual? These are the individuals having diabetes mellitus, your DM. Now, these people who are mostly elderly, critical illness, immunocompromised, diabetes, they get this infection by gas forming organism. Now, what will be the clinical features? What will be the clinical feature? All the clinical features of acute cholecystitis, acute cholangitis, like right upper quadrant pain, fever, and etc., nausea, vomiting, all that is going to be there. Okay, we know that it is a disease of the gallbladder, but what makes it stand out is that sometimes, not in always case, sometimes there is a crepitus heard over the region of gallbladder in the anterior abdominal wall. And obviously now in the patient, even if he has crepitus or he does not have crepitus, he is having right upper quadrant pain, fever, you suspect I should do a right upper quadrant ultrasound, you do a right upper quadrant ultrasound. The thing that is going to stand out in the right upper quadrant ultrasound, or if you do a CT also, is that there will be gas. Gas in gallbladder. But there is a but here. What you need to know that there won't just be gas in gallbladder. There will be gas in wall wall of the gallbladder as well. In the gallbladder wall as well. This is very important. Why is this also important? Because there is another condition where there can be gas in the gallbladder, but it is not emphysematous cholecystitis. What is that condition? See, that condition is biliary enteric fistula. What is that? What happens is, if this is the gallbladder, this is the stone in the gallbladder, and over here are your intestines running like this stone, what this stone is doing is it is continuously irritating the wall. The stone is continuously irritating this wall. It is continuously causing irritation, and over the time, because of the chronic irritation, there is going to be a gap over here. This gap over here, the stone is going to go away. The stone is going to go away here, creating a connection between the intestine and the gallbladder. Between the intestine and the gallbladder, there is a connection, and because there can be gas in intestine, there will be gas in gallbladder on the ultrasound. But here also there won't be any gas in the gallbladder wall. So if there is this thing, gas in the gallbladder wall, then you need to know that it is emphysematous cholecystitis. And then what will you do? You will treat with the best or the most broadest antibiotic which is possible. Generally, what the recent they say is you treat with peptase, piperacillin, and tazobactam is what you have to give in such a case, and then you can do cholecystectomy. Now I will be showing you the CT image of emphysematous cholecystitis, and this CT image can be asked in your exam, and you may be asked what is this condition, diagnose this condition, or they can ask tell you this is the CT image, this is the symptoms, what is the appropriate antibiotic. So the CT image is over here, emphysematous cholecystitis. Here you can see that there is gas within the gallbladder wall. Moving on to the next condition. Now imagine you have got everything that is of cholecystitis and of cholangitis. Everything is falling into the picture, but there is a twist. The twist is that there is no gallstone. Here acute cholecystitis, there was a gallstone. Acute cholangitis was also because of a gallstone. Biliary colic is also because of gallstone. But over here, the next condition that we are discussing is almost similar to all these conditions, but there is no gallstone. Without any gallstone, there is inflammation of gallbladder, and biliary to certain extent biliary trees. Here I am putting a star mark because majority it is inflammation of the gallbladder only. In what type of patients is this seen? This is seen in severely severely ill patients who are severely ill. Now they can be severely ill, they can have sepsis, or it could be anything that is putting them under ICU, mechanical ventilation. So these are severely ill people. In those people, because of stasis, because of biliary stasis, even though there is not formation of any gallbladder, just because of the stasis, there is inflammation of the gallbladder wall without any stone. Just the bile itself, just the gallbladder wall itself is becoming inflamed. Now you will be asked, what is the treatment? How will we treat it? If there was a stone, we were removing the stone. Here, even though there is no stone, the treatment is still antibiotics, because there can be infection in the inflamed gallbladder, and even though there is no stone, you still will do the same thing, antibiotics and ERCP, and that is you will go with your endoscope till the sphincter of Oddi, and if this is the gallbladder over here, these are the both the hepatic duct. This is the common bile duct. Over here is the pancreatic duct. This is the ERCP scope. You will still go over here and you will relieve the obstruction. Relieve the obstruction and clear whatever fluid is there. If this is the gallbladder, even though there is no stone in the gallbladder, it is having some fluid, and there is some fluid within the biliary tree. Whatever fluid is there, through ERCP, you have to remove that fluid. You have to remove that fluid. Once all the fluid over here is gotten out, now the gallbladder wall can get space and time to heal itself. Now is when the gallbladder wall will get space and time to heal itself. Meanwhile, you are giving antibiotics also, and also you can do elective, if there is a chance you can do elective cholecystectomy also. But the primary treatment will be antibiotics and drainage via ERCP. Now, in all these conditions that I have discussed till now, if we see in most of these conditions, if not all, at least in most of these conditions, what the final treatment is the removal of gallbladder. But sometimes what can happen is even after removal of the gallbladder, either immediately or after a few years, you will get the same symptoms. Such a condition is called as, over here I am discussing, it is called as post-cholecystectomy syndrome. Now, in post-cholecystectomy syndrome, what will happen is that I have drawn a beautiful diagram, kept it ready for you people. Now, even though we have removed the gallbladder, this was the gallbladder which is removed from here. Now it is not there. This gallbladder is not there. It has been removed by cholecystectomy. Still there is the hepatic ducts, and still there is the common bile duct. Still there is the common duct meeting with the pancreatic duct opening into the sphincter of body. So bile is still being secreted. Don't think that bile is not now being secreted. Now, what happened is at the time of removal of gallbladder cholecystectomy during the last ERCP, what will happen is that there might have been a stone in the CBD which is retained. Even if the stone is not retained, you have clearly removed all the stones, still there can be formation of new stones, because even though stones mostly only form in the gallbladder, they can still form without presence of gallbladder also. The chance is less, but chance is still there. If so, for example, the person is having hypercholesterolemia, in such cases still there can be a stone. Or what will happen is when the surgeon is removing the gallbladder, he inadvertently, means by mistake, by not knowing, he by mistakes damages a part of the biliary tree. Any of this part is damaged of the biliary tree. Now, this any damage during surgery, after some time, it is going to present as a stricture. Yes, it is going to present as a stricture. I will use a gray pen for stricture. Now there is stricture. If there is also stricture over here, then again it can present in the similar manner as acute cholecystitis. This is called as acute cholecystectomy syndrome. Then what is the treatment? The treatment is that you go in again. You go in again via ERCP. You repeat the ERCP. By the way, I am telling ERCP, ERCP. What is ERCP? I hope that you all know that ERCP is endoscopic retrograde cholangiopancreatography. Okay, so you again go through the endoscope. You take your endoscope. This is your endoscope. Again, you go through the endoscope. You see here, you visualize here whatever is the problem. If there is a stricture, if there is a stone that is there, you remove it, you treat the thing, you visualize the biliary tree. What will happen sometimes is there might be extra biliary causes of a post cholecystectomy syndrome. What are extra biliary causes? Like coronary artery disease is there, peptic ulcer disease is there, These, the list goes on. The list is not relevant to us for our competitive examinations. Just you need to know that what is the treatment of post cholecystectomy syndrome. The treatment is ERCP. Now coming to another complication of ERCP that can be there is that suppose a patient undergoes ERCP by any reason, if there is a, by any reason he undergoes ERCP or he undergoes a liver biopsy, any hepatic or biliaro-pancreatic procedures, generally speaking ERCP. After that, after 2 days, 3 days, 5 days, he develops right upper quadrant pain. See, right upper quadrant pain. I am talking again and again, right upper quadrant pain, right upper quadrant pain. All these biliary system disorders, they have right upper quadrant pain. Jaundice. Most of the conditions till now I have spoken, they also have jaundice. But this is the unique finding that he has melena. What is melena? Melena is black or tarry stools. What does melena indicate? It indicates upper GI bleeding, that there is bleeding somewhere in the upper GI tract. It is going downwards, coming out through the poop, and because it is going all the way from the upper GI, it is not a fresh bleed, it is visualized or it appears as a black or tarry stool. So, remember this combination: right upper quadrant pain, jaundice with melena, recent ERCP. Now the condition in is hemobilia. This is called as hemobilia. What happens at the time of ERCP when if this is the gallbladder, these are the both the ducts, this is the common duct. Over here, if there is the opening, sorry, huh, over here, if there is the opening over here, what, and you go through the probe, you are going through the probe, you are doing ERCP to visualize the biliary tree, and while visualizing the biliary tree, to you accidentally hit the biliary tree itself, a part of the body itself. Now there is bleeding from here. There is bleeding from here. There is bleeding from here, and it is going to bleed down and come out as melena. And this injury you have caused over here, this is going to present as right upper quadrant pain. Since there is blood here, the blood is obviously not going to keep on bleeding. Some, it's going to coagulate till some extent, it is going to cause some obstruction. Because of the obstruction it is causing, backwards there's gonna be obstruction. Because of this there is going to be jaundice. So in hemobilia the patient develops first jaundice, second right upper quadrant pain, third melena. These are the three symptoms that he develops. Now, literally, so much has been discussed about gallstones, and now we'll come to the last part about gallstones. And I have slightly touched on it little bit, is that it can form biliary enteric fistula. I will show it to you here. While discussing emphysematous cholecystitis, we had discussed that sometimes if a gallstone is obstructing, it is continuously obstructing the gallbladder wall. Not obstructing, sorry, I meant to say putting pressure on the gallbladder wall. This is the gallstone, it is continuously putting pressure on the gallbladder wall. It can lead to dissolution of the gallbladder wall, and basically the neighboring intestinal wall is also dissolved, and it will leave what you called is a Biliary enteric fistula, a fistula between the gallbladder and the intestine. Now, what I had not told you is that this gallstone which leaves, suppose if this is the gallstone, this is the gallstone which has left. This gallstone can create its own problems in the small intestine. How can it create its own problems? It can get obstructed somewhere. What is the part where it can commonly get obstructed? It will obviously get obstructed in the part which is having the smallest diameter. Now, which is the part which is having smallest diameter in the entire alimentary canal, excluding, let's say, the esophagus, stomach, in the lower alimentary canal, I meant to say, that is the ileum. It will get stuck near the region of ileum till the cecum. If this is the ileum, this is the cecum. The stone will get stuck over here, or this is the most common place. It can get stuck anywhere. So imagine this. This will be the case scenario asked in your exams. The case scenario that will be asked will be that there is a lady who was having symptoms of repeated biliary colic. Symptoms of repeated biliary colic. She was having symptoms of repeated biliary colic, upper quadrant pain radiating to the shoulder, and it was dull, accompanied by nausea, vomiting, used to go away by itself after, let's say, 4 to 6 hours. Now she is coming to you with symptoms of small intestinal or large intestinal obstruction. What are the symptoms? She is having severe abdominal pain. What she is having? She is having severe abdominal pain. She is having nausea, and she is having severe abdominal pain. She is having nausea, vomiting. All this is very non-specific till now, but decreased appetite. She doesn't feel like eating anything. She has a feeling of fullness, abdominal distension. So you examine the abdomen. In the abdomen, what you will find is hyperactive bowel sounds. Hyperactive bowel sounds. Why you will find this? Because the abdomen is constantly contracting. It is constantly vigorously contracting against the obstructed region. This is the reason for abdominal, these sounds, hyperactive bowel sounds. Then you do the ultrasound. What you will find on the ultrasound? Ultrasound reveals that there is dilated loops of small intestine. These dilated loops of small intestine will also be there on X-ray, by the way. Dilated bowel loops plus dilated bowel loops is indicating of intestinal obstruction. Plus on top of that you will find gallbladder air. And where this air will be? In the lumen of gallbladder. Never, never in the wall of gallbladder. If it is in the wall of gallbladder, then what your suspicion should be? Your suspicion should be your emphysematous cholecystitis, not gallstone ileus. This condition, particular condition, what I am talking about is the gallstone ileus. Now let us move to this topic called as porcelain gallbladder. Porcelain gallbladder, if I am pronouncing it right, I hope I am pronouncing that right. Now, what happens is I want you to recall your basic pathology, your basic inflammation chapter of your basic pathology. Anywhere in the body, if there is repeated inflammation, repeated inflammation or there is chronic inflammation, the body's response to this is in many ways like adhesions, fibrosis, and many times strict strictures is one thing. Many times the response is by calcium deposition. If the body cannot fix something, it will put lots of cement around it to stop it. What is cement of the body? Calcium is the cement of the body. This is what I want, or I want the students to remember that if the body cannot find a way to heal something, it will put calcium around it over the period of time. So when this happens with the gallbladder, because of repeated inflammation and repeated chronic inflammation in the gallbladder, slowly because of repeated biliary colic, repeated infections of the gallbladder, there is calcium deposition around the gallbladder. This is called as porcelain gallbladder. Why are we reading this? Why it is important? Because this condition there is increased risk of adenocarcinoma, and if there are any symptoms, if symptomatic, or if any problems are there, you can go for cholecystectomy. But what is important from exam point of view, from your competitive exam point of view, are the images of this, because it produces very unique images which I will show to you in a minute. See, this is the x-ray. Here in the red dot you can see this thing which is having this whitish lining. This is nothing but calcium in the lumen of gallbladder. You can see this here. This is the calcium around the gallbladder. You can actually visualize the gallbladder by the calcium that is deposited around the gallbladder. Now I'll show you the CT image. Yes, on the CT, this is the gallbladder. This this area, this area is the gallbladder, which is completely surrounded, completely the calcium has been deposited over there. You compare this with the vertebrae, it is almost the same look as that of the bone. So I want you to remember the city images, all the radio images. First, this image is of porcelain gallbladder. This image we have discussed, this is also of porcelain gallbladder. There is another image. This is the of emphysematous cholecystitis. So till now we have discussed three radiological images. Now we will start this new topic, and this is a very important topic as it is usually getting confused with the acute cholangitis, acute bacterial cholangitis. This is primary biliary cholangitis. Now, what is primary biliary cholangitis? What happens is in this condition, if let's say this is your liver, one second, if this is your liver and within the liver there are left and right hepatic duct, these ducts have another many branching out, many different small hepatic ducts are there, different small hepatic ducts are there. If we magnify this and take this section, this is a small hepatic duct. Now if there is an autoimmune reaction against this small duct, autoimmune reaction against this small duct, what is going to happen? The autoimmune cells are going to come here. If these are the autoimmune cells, they are going to come here. They are going to destroy this area. Then there is going to be fibrosis over here. This area is going to get fibrosed. So imagining it in the bigger picture, this is the fibrosis due to autoimmunity of intrahepatic. Mind my words over here. Intrahepatic bile ducts. Then how is it going to present? It's going to present with this is a lady who is generally affected ones are females. This is a lady who is in her 30s to 60s. 30 to 60 years. She has other autoimmune conditions also. Like the question might say that she is having thyroid problem or any other autoimmune problem, they will give you in the question stem. And she will have pruritus, which is itching, which is generalized and which is not relieved by antihistamines, not relieved by your antihistamines. Okay, she has pruritus, she has fatigue. Along with pruritus, fatigue, and other autoimmune problems, she has everything else which you see in this condition. In acute cholangitis, like she also has jaundice. She is also, if not fever, she has right upper quadrant pain. So she has jaundice. She has right upper quadrant pain. One thing particularly is we understand that there is jaundice because there is blockage over here, there is blockage over here. So the bilirubin is going to go backwards. It will lead to increase in unconjugated bilirubin. But not only that, it will cause increase in unconjugated bilirubin, it will also cause an increase in body lipids, means increase in body cholesterol. So because of the cholesterol that is increased in the body, she will also have, she can also have over here exanthalasmas. What are exanthalasmas? I will show you in 1 minute. This is what is an exanthalasmas. These are lipid laden macrophages. To say it in simple word, this is nothing but this is the extra cholesterol, and the lesion is because of the extra cholesterol that is there in the body. If you see this in the patient, you say that this patient is suffering from high lipid levels, high cholesterol levels, something like that. Now, what do you do in such a patient? In such a patient, if you once diagnose antibiliary cholangitis, how will you diagnose that? That other than all the findings which are there of cholangitis, the most important findings which you need to know for your exam point of view is positive anti-mitochondrial antibody. This is going to be there along with other ultrasound and other findings. The most important finding for exams is going to be this. Okay. So if this is there, what do you do? How do you do the treatment? The treatment is going to be by UDCA, urso deoxycholic acid. It has anti-inflammatory and immunomodulatory effects, and it is shown to decrease the progression of PBC. And this is your PBC. It is shown to decrease the progression of PBC. What will happen? What is the last stage of PBC? That there will be biliary cirrhosis. There will be cirrhosis of the liver because there is blockage over here. Eventually, the hepatocytes themselves will get damaged. Damage is going to be over here on the hepatocytes. The hepatocytes themselves are going to get damaged, and eventually there will be cirrhosis. And so what you do is you give UDCA, you start UDCA, you decrease the product the progression of the disease. But once it reaches liver cirrhosis and there is decompensated liver failure, you should go for liver transplantation. Now, coming to the last topic of today's discussion is of a pediatric population. It is cholestasis in neonates. Now, what do you mean by cholestasis? It is the stasis of bile, slowing of the bile. Now, how does it going to present? Now, it is going to present with jaundice in a child, and there will be dark urine and pale stools. Why there is going to be dark urine and pale stools? I am going to explain it to you. Whenever there is conjugated bilirubin, that conjugated bilirubin, if it cannot pass down in the manner in which it is supposed to pass down, it goes and mixes with the plasma and it is excreted in the urine. So it gives the urine a dark color. Whereas since it is not passing down in the intestines, there is no stercobilin production. Stercobilin is not produced, and that is why the stools have a pale color. And whereas the conjugated bilirubin is mixing with the urine, giving a urine a dark color. So whenever you see this combination in a neonate or a small child, what do you need do first is you get an ultrasound done, USG done first. In the USG, there are three scenarios now which are possible. The first scenario is where you do not see the biliary tree. The biliary tree is absent, the gallbladder is absent, or it is small, rudimentary gallbladder. This condition is called as biliary atresia. Atresia means lack of development. What has happened in this condition is that if this is the liver, this was supposed to be your by this thing biliary tree, this has not properly developed. This has not properly developed and it is rudimentary. Like this is very small. Because of this, the bile cannot pass. If the liver is making the bile, it cannot pass. So it will go backwards and it will cause jaundice. Since it is not going forwards, it will cause pale stools. And since it is getting mixed with the blood and plasma and eventually the urine, it will cause dark urine. This is one condition. The other condition is on the ultrasound, what you might see is in fact dilated biliary tree and distended gallbladder. We will discuss this in a minute, but because this requires a lot of discussion, there is also a third possibility that everything in the ultrasound is normal, or there is just hepatomegaly, the biliary tree is normal. In such case, in such case, the underlying cause is either genetic or infectious. The underlying cause is either genetic or infectious, like cytomegalovirus, herpes simplex virus, HIV, endless. But if the biliary tree is dilated and the gallbladder is distended, now we are coming to an important diagnosis. This is a biliary cyst. This is a very important topic, biliary cyst. Now we'll discuss biliary cyst in detail. If I get space to write down, okay. Biliary cyst. What is a biliary cyst? If this is the regular biliary tree, left and right hepatic duct meeting with the cystic duct and the gallbladder forming the common bile duct, this is the normal condition. Somewhere there is a cyst, means over here there is a cyst. This is your gallbladder. There is a cyst. The cyst can be here, the cyst can be here, the cyst can be here, cyst can be here. There are 6, 7, 8 types, but I want you to remember, instead of mugging all the types, I want you to remember what this cyst does is this cyst causes stasis of the bile, and because there is stasis here, there is backward pressure, backward pressure and backward dilatation. Because of this backward dilatation, you can visualize a dilated biliary tree on the ultrasound. Now, if we see a biliary cyst, it is a problem. We need to remove it with a cystectomy. With a cystectomy. Why we need to remove the cyst? We need to remove the cyst because it causes increases the risk of cholangiocarcinoma. There is an increased risk of carcinoma, so you need to remove the cyst. But will you immediately remove the cyst? No. First thing to do is, because there is backward pressure, because there is backward dilation, because there is stasis, because there is jaundice, what you will do is, first you will go inside with a ERCP probe. With a ERCP probe, you will go inside and you will relieve the obstruction. You are going to relieve the obstruction first, and then you are going to remove the cyst. Later on, you are going to remove the cyst. Now, this biliary cyst can be found in a neonate, it can be found in a child, and sometimes even in a young adult. But whenever you find it, you remove it.